Just a couple questions that hit real quick before we started. Alex asked about any update on the Maverick modules for Symposium. I think the university is finally paying for the contract today. So as soon as they get that, Dina has your emails already, and she'll send out the Maverick information. So I would anticipate hopefully that being done by next Monday, but I'll let you know for sure. And I'll touch base with Dina later. So that'll give you over a month to get everything done, which is pretty doable, especially since you don't have much going on in this class. All right, so acute pain, there's a lot of information here. Most of it should be a refresher for you. So we're going to kind of go through stuff pretty quickly. I'll focus on some things that I think are really important for you and things you'll probably see again. So things we have to think about, we worry about pain from the psychological factors, but really there's a lot of physiologic things that come into effect. If somebody's in pain, their heart rate goes up. If they're in pain, they may breathe faster. You may see that things kind of get out of whack from a glycemic standpoint. Blood sugar may go up, blood sugar may go down. The other thing you see is that patients can be in pain and manage it, but at some point it gets to where they're not able to control themselves anymore. So a lot of times we see a more exaggerated response from severe pain as opposed to lower level pain. So we try and manage our pain as best as possible. There's two main types of pain that we talk about. You have somatic pain, which is generally kind of superficial pain, although you may see it involves things like muscles, tendons, bones. And then you have visceral pain, which tends to be a little bit more localized to organs. So a lot of times when we're trying to control things like surgical pain, there's a somatic as well as a visceral component to it. So say, for instance, somebody's having a lap chole done. The surgeon may inject a local anesthetic at the skin, which will help with the somatic pain, but it doesn't do anything for the visceral pain from the ports being put in or something like that. So when we're trying to control pain, we really have to account for both those factors. So whether we're using something systemic like an opioid or something selective like a nerve block, we've got to kind of control both of those approaches to it. The goals for pain control are pretty straightforward: optimize our patient's comfort level and really try and block out any sort of adverse physiologic responses. If we do those two things and we do a good job of it, we tend to prevent the formation of chronic pain syndromes. And then we also control the anxiety and agitation of our patients. So, how do we do that? There's a variety of strategies out there, and we're going to kind of talk about each of those today. Preemptive and preventive analgesia is probably one of the biggest things, because if we're able to control the pain before it happens, you don't have quite the same risk of the agitation, the sympathetic responses, the development of chronic pain syndromes. So how do we do that? Currently, we use kind of a multimodal approach to do that, hitting as many receptors as possible. But with that in mind, you really have to target your analgesic plan to the patient. There's also a very high incidence of opioid-free anesthesia being utilized right now. I'll go into that a little bit, but when you look at that opioid-free presentation, it really provides a lot of information, not only on why we use opioid-free anesthesia, but also kind of the benefits of it, and then some examples and guidelines. So we really deal with about three phases of pain. Most of what we're going to talk about today is going to be acute pain. But if we don't control pain at the start, then we run the risk of developing into nociceptive pain or neuropathic pain. Now, you can have patients that start off with essentially neuropathic pain. Think about somebody with diabetic neuropathy. They may never really have an acute pain phase. In fact, they may have the exact opposite, that they never have the acute pain because they don't have adequate sensation. So with those patients, neuropathic pain may be their start. So what causes pain? These are just some examples of things. Anything can be painful to us. We think of injuries. We think of kind of chronic conditions like osteoarthritis. We may also see that pain is really a symptom of an underlying issue, say something like peripheral artery disease or vascular occlusion. We also see it with malignancy. We may see it with cardiovascular disease like chest pain. So lots of different things can cause pain. It may just be really a symptom of what's going on. But these are examples of disease states that cause pain. We also see that pain can be caused by immobility. So things like patients that are bedridden because of dementia or a stroke, or orthopedic concerns like degenerative joint diseases, fractures, amputations, those sorts of things may cause pain. So one of the things that we oftentimes forget about is mobility may really be the best solution for treating pain. So for instance, you have somebody that had that lap chole done. We did a good job of infiltrating the skin. We provided them with appropriate opioids, but afterwards they continue to be in pain. The best thing we may be able to do is get them mobile, get them up out of bed. They're able to mobilize some of that gas that's inside their abdomen, and that really takes care of the last little bit of pain that they're experiencing. So there's some things we worry about from a pain standpoint, and we call these red flag signs. And you can see red flags come from a variety of different things. So constitutional symptoms, and what I mean by that is that somebody has pain, but they have also had loss of bowel or bladder function. So maybe they have back pain and it's a chronic condition, or maybe it's acute back pain. You fall and you're doing okay, but the next day you wake up and you're incontinent. That's a huge red flag. Pain that is severe enough that it awakens you from your sleep. Again, another red flag. Pain to the point where it's causing immunosuppression. Oftentimes, with malignancy, we'll see that patients develop severe pain as their presentation, and then they go in and they've got something like osteosarcoma. If you have patients with neurologic deficits, especially if they're severe or if they're progressing, another red flag. Patients with vascular occlusion that leads to the point of like a cold, pale, or mottled extremity, big red flag. Like I said, bowel or bladder dysfunction. And then any real severe pain, especially in the abdomen, because there's so many different contents in the abdomen, it can be kind of hard to isolate things. So if you have somebody that's got severe abdominal pain, or they have severe abdominal pain that's associated with hypotension, elevations in white blood count, fever, any sorts of signs of peritonitis, be very cautious with those patients. So we touched on this a couple of minutes ago, but what happens if we don't manage pain? So say, for instance, I have a patient with an extremity fracture. They're 65 years old. They've got a history of CAD, and their pain is not adequately controlled. So from a physiologic standpoint, what I'm going to see is that they start to become tachycardic, they become hypertensive, they've got a huge increase in cardiac workload. So for most of it, that's no problem at all. But what about that patient with CAD? That tachycardia may be enough to start inducing demand ischemia. So something as simple as pain could be devastating to that patient. We may also see that somebody with rib fractures doesn't breathe well because they have pain. As a result of that, you may see that they hypoventilate, they start to develop hypoxia, atelectasis, and next thing you know, they've got pneumonia. Just a simple, inadequate pain control results in that. From a GI standpoint, we may see that because of pain, they develop an ileus. Not kind of following the best evidence-based guidelines may also result in that ileus. So if you've got somebody that's post-abdominal surgery and you're giving large amounts of opioids, that may be enough to slow their GI function and they develop an ileus. So lots of different examples of how inadequate pain management may worsen patient conditions. We're going to talk a little bit about three big theories of pain, and you'll probably see these again. But the specificity theory came from Rene Descartes. And what he suggested is that the intensity of the pain is directly related to the amount and the degree of pain associated with the tissue injury. So basically, what he was kind of saying was that it's its own specific sensation and it's got its own pathways, it's got its own system without involving any other type of sense. So this is kind of how we started off thinking about pain. But one of the issues that we ran into was that it really kind of doesn't understand the intensity. So, for example, if you hit your finger with a hammer versus a small needle, the pain will be very different in intensity, and that intensity is very indicative of tissue damage. So from that standpoint, the intensity theory does a pretty, or the specificity theory does a pretty good job of explaining the phenomenon. But that's not really how things work, because you have to involve other senses like seeing, feeling, and those may impact things. You may have a, apparently devastating injury that's got lots of blood, but in reality, there's not much tissue trauma. So from that standpoint, the specificity theory would overreact to the pain. The intensity theory is kind of the exact opposite of that. It really thinks of pain as more as like an emotional experience than a sensory experience. So interesting approach, but not necessarily accurate. And the gate control theory is really the best theory of pain we have right now. There's still some issues with it, but it was proposed by Melzack and Walls in the mid 60s. And it really kind of takes everything into account, acute pain, comprehensive pain, and it's kind of how we work from now until we're starting to see there's some issues with it, like I said, but this is really the most accurate kind of pain transmission theory. And basically, what it proposes is that pain transmission is modulated by a balance of impulses that are transmitted to the spinal cord, and then it's modulated or regulated through these gates that transmit the perceptions onto the central nervous system. So, kind of makes sense. It includes a little bit of pathophysiology that we didn't really think about before. So when you think about acute pain, we see that there's two main fibers that we deal with. You have alpha and C fibers, and these fibers transmit things a little bit differently depending on whether they're myelinated, unmyelinated, and then the size of the fibers. You'll want to remember this slide, but when we think about pain pathways, we think about three different order neurons. So you have first order neurons, which is really where things start off. So first order neurons are basically the periphery to the spinal cord. Second order neurons are the transmission from the spinal cord up to the brain. And then third order neurons are actually in those ascending pathways from the spine into the brain. So as I said, first order neurons really start at the periphery and the skin itself. Then they travel to the spinal cord where they synapse with the second order neurons. Inside the second order neurons, the dorsal horn of the spinal cord synapses with the second order neurons, and it crosses to the opposite side of the spinal cord. And from there, it goes up the spinal thalamic tracts into the thalamus. And then inside the thalamus, the third order neurons project through the internal capsule and spread to the postcentral gyrus of the cerebral cortex. So first order is periphery, second order is spinal cord, third order is in the brain. These are the two main pain transmission fibers that we see. A delta is a very large myelinated fiber. As a result of that, we tend to see very fast transmission of it. C fibers are not myelinated and they're a little bit smaller, so they're not quite as fast. But both of those are responsible for pain transmission from the periphery into the spinal cord itself. So we see that there's four different processes that happen as far as like the elements of pain processing. These are important to remember because when we start thinking about how we can affect the different processes, we're really targeting the different levels here. So you start off with transduction. Actually, we'll start off with perception. So perception is really what happens where you start integrating the painful input into the somatosensory and the limbic cortexes. So you have a painful stimuli, you perceive that that's happened, and then it carries on to modulation. And this is where the pain transmission starts affecting the different neural processes. You have transmission, which is where through the action potential, you conduct these impulses through the nervous system. And then you have transduction, where the noxious stimuli is originally converted into an action potential. So two terms you want to make sure you're familiar with, allodynia and hyperalgesia. What you see a lot of times with neuropathic pain is that patients will have both of these. Allodynia is really a pain from a stimulus that doesn't normally induce pain. So think, for instance, somebody with diabetic neuropathy. You may see that just rubbing their foot is extremely painful, something that wouldn't normally cause pain to anyone. And then hyperalgesia is really an exaggerated response to something like that. So these are some examples for you. And we have what we call primary and secondary hyperalgesia. Primary hyperalgesia is an augmented sensitivity to painful response or a misinterpretation of something that's non-painful. Um, One of the problems we run into with a lot of our medications is that they can actually be a cause of hyperalgesia. So, for instance, remifentanil can cause hyperalgesia. It's a very potent opioid, but you'll see patients that get just remifentanil without long-term pain medications or without something like ketamine may cause hyperalgesia. And then you have secondary hyperalgesia, which is an increased excitability of the neurons in the CNS due to activation of the glutamate activation of the NMDA receptors. And that's why it's so important to make sure that these patients are getting ketamine or something of the like to help decrease the incidence of hyperalgesia due to that NMDA receptor activation. This is just kind of a chart that really goes over what I talked about. So what you see is that if you've got a patient with a normal pain response, how they shift to hyperalgesia and then to allodynia in a chronic pain state. Um, you may also see that if you've got somebody with central hypersensitivity, it may really play a long-term role in the patient pain complaints. If they've got that, a lot of times either no stimuli or undetectable tissue damage will result in pain. So things like an innocuous stimulation or a minimal stimulation really kind of generates an exaggerated response to those folks, which is kind of hard for us to recognize a lot of the time. So if we have a patient with neuropathic pain, um, they've had kind of complete or partial denervation of the body part. So generally what happens is it results in numbness, but it may also result in pain, depending on how severe the denervation is for those patients. So that's just kind of a quick overview of the different types of pain we see and how they happen. Now we're going to kind of transition from that into some pharmacology. So things we have to think about for patients in terms of pharmacology is some of the effects we see with changes in age, and then other factors we don't consider. A lot of times, from an anesthesia standpoint, we think about just parenteral medications. We don't think about things like oral administration of medications, which now we're starting to see more and more often that we give patients PO medications that come into play. So it's important for us to really understand how those work. So what we see in patients is they age, which a lot of our patients do, is that they have decreased GI motility and blood flow. Um, a decrease in gastric acid secretion, which results in an increase in pH. Um, if we use more and more medications, we tend to see that that alters the pH. You may also see that there's more gastrointestinal side effects in patients with increased medication usage. Um, as a result of that, you do have to consider the fact that they're affected by first pass metabolism. Um, with that in mind, you generally see minimal effect on absorption, but what you will see is that there tends to be an increase in effect of complaints. Those older patients generally will kind of have a proportional absorption of the medication. So think about how your medications bind to proteins, what the pH of it is. All the PK and PD really come into play for these patients, but you tend to see extraneous factors like the free water, their nutrition status. For instance, if you have something that's highly protein bound, but they're malnourished, they may have very low albumin levels. Sometimes we will administer albumin just to potentiate our medications and to help with wound healing. Orthopedic surgeons are very good about following patients' albumin levels because they know their wounds will never heal if they're malnourished. Other things you see in older patients, overall a decreased muscle mass, an increase in body fat. And as I was talking about before, you tend to see a decrease in total body water as well as albumin. So those are two things we really have to take into account. From a metabolism standpoint, most of our medications are metabolized in the liver. So if you have somebody that has a liver issue or somebody that's just a little bit older, we tend to see that there's a decrease in hepatic blood flow. We also see that there's usually a decrease in the liver mass and its underlying metabolic activity. The kidney is really the primary organ we use to excrete things. Again, as we age a little bit, we tend to see that there's a decrease in blood flow, there's a decrease in renal mass. It's a lot less functional in terms of nephron. Generally, our GFR is going to drop off as we age, and that's really how we trend renal function in older patients. So that may be a good starting point for you, either that or BUN and creatinine. So the World Health Organization put together what they call the pain relief ladder. And this is really how we approach pain, whether it be acute or chronic. And the important thing to take away from this is the recognition that patients may not need opioids is really their first intervention for pain. Because historically, we've jumped to things like fentanyl and morphine as our pain management tools for stuff that may not really be that painful, or perhaps they've already had interventions done and we really just need to follow up on them. So, the first thing they really recommend is non opioid medications. So, we use lots of NSAIDs at this point. And you can also think about kind of adjuvant therapy for these people. Things like physical therapy, braces, heat, cold, movement. Remember, we talked about how being bedridden or non functional can cause pain. If they continue to have pain after that, we may then consider opioid therapy. But we usually go ahead and consider whatever non opioid therapy we're using, as well as the adjuvant therapy. And then we'll continue on from that point to a little bit stronger opioids. But I think the important takeaways from this are one, to remember that we usually start off with non opioid medications for pain. And then two, even if we start using opioids, we want to go ahead and continue whatever non opioid therapy we were using. And this is part of the reason that we consider using opioids versus non opioid medications. Most of our opioid medications act centrally, they're really more of a depressant effect than treating anything, whereas most of our non opioid medications act in the periphery. There is a risk of tolerance, dependence, and addiction with all the opioids. You will see some of that with the non opioids, but it's generally not as serious, and you don't have to worry quite as much about addiction as you do with the opioids. Obviously, opioids are controlled, whereas the non opioids generally are not. Um, there are associated side effects with both of them. Generally, these opioid side effects are considered to be a little bit more severe. Things like sedation, respiratory depression, constipation, hypotension. The non controlled substances generally have a little bit more gastric irritation. So, things about things like ulcers. They do have a risk of bleeding, especially with a little bit higher doses. And then, since most of them are managed in the kidney, there's a little bit of an incidence of renal toxicity for those patients. A lot of our non opioid medications work through controlling inflammation, whereas most of our opioids have nothing to do with the inflammation itself. So the NSAIDs may actually help with the source of the pain in addition to treating the pain, whereas the opioids really just managing the systemic pain itself. There's really not a ceiling effect for most opioids, so we can just keep giving more and more and more and more. Um, that's how oftentimes where we get ourselves into trouble because patients develop a tolerance, so we just keep giving them more opioids and more opioids and more opioids instead of recognizing that the therapy is probably not working for them and we need to consider something else. Um, you will see that with non opioids, there tends to be a little bit of a ceiling effect. But what you do see is that the increase in dose doesn't necessarily increase the analgesia, but you start to see side effects. So good examples of this, especially if anybody was ever in the military, like their solution for everything is water and 800 milligrams of Motrin and new socks. Um, the reality is when we look at dosing for ibuprofen, most patients will get adequate coverage with 400 milligrams. without any sort of adverse events. That ceiling effect we then continue on because we've met that ceiling right there at the 400 milligrams. But you'll see lots of times that people will use 600 milligrams, 800 milligrams, and really don't get any increased benefit from it. But that's when you tend to start seeing abdominal pain, increased risk of bleeding, that sort of thing. We also see the same thing with something like Ketorolac. 15 milligrams is really the ceiling effect of it, but lots of people still give 30 milligrams, 60 milligrams. These are the big receptors that affect opioid analgesics. Mu is probably one of the most common ones that we see. And that's really what results in the analgesia, but it also results in a lot of our complications. That's where the respiratory depression comes from, the decrease in GI motility, that kind of high feeling those patients get. Kappa also results in analgesia, but it results in a little bit of dysphoria, and you can get a little bit more of the psychological effects here: psychosis, delusions, delirium, meiosis, and also some respiratory depression. The delta receptors really are the least devastating of any of them because we usually just see that results in analgesia as opposed to any of the real adverse effects that we see with the other ones. So we're going to talk a little bit about opioids. As I said, they're really our go-to pain medication and have been for such a long time. But we're starting to recognize that there's more and more complications of using opioids as our primary go-to for pain management. So they all are derived from opium or synthetically related to opium. They bind to the opioid receptors, acting directly on the central nervous system. Remember, we talked about they're really central agents as opposed to peripheral agents. And all they do is just reduce the perception of pain. They don't treat the cause at all. They just make the patient kind of not notice how painful things are at that time. So now we're going to talk a little bit about the different opioids and kind of why you would use one versus the other, because there's certainly a wide gamut of medications out there. These are a lot of the PO opioids we see, or the kind of long-term opioids. So codeine is also known as Tylenol number 3 or Tylenol number 4. We're familiar with the IV fentanyl, but don't forget that it's also available as a topical patch. Hydrocodone is also known as Lortab or Vicodin. Hydromorphone is also known as Dilaudid. Methadone's trade name is Dolphine. You'll see morphine referred to as a variety of things. And a lot of these medications are similar. You may just have different names based off of the duration of action. So, for instance, oxycodone in the intermediate release formulation is Oxy-IR. You will also see it listed as Oxy-ER for the extended release formulation. So just be familiar with what options are out there as far as PO medications for your patients, because that may be your best approach to the acute treatment of pain. So now we're going to talk a little bit about some of those specific opioids and kind of indications, contraindications, where they come from, and really benefits or drawbacks to those medications. So codeine is also known as 3-methoxy morphine. Benefits of codeine versus morphine is it tends to be more reliably absorbed than oral morphine. So oftentimes we'll put patients on long-term codeine-based medications. You also commonly see that it's co-administered with Tylenol. So you may have acetaminophen with codeine, Tylenol with codeine, and then the dosing really varies between the Tylenol number 3 and the Tylenol number 4. Metabolized by P450, as most of our medications are, to morphine. And generally what you see is that it tends to stick around for a long time. As a result of that, and the way it's actually processed, we avoid using codeine in children because they're lacking an enzyme that really is necessary for processing it. So as a result of that, they tend to have all the side effects without any sort of benefit. Dosing wise, adult dosing, I know it says 15 milligrams there, but if you're doing Tylenol number 3, it's 30 milligrams. If you're doing Tylenol number 4, it's 60 milligrams, with a limit of 360 milligrams a day. So, 4 to 6 doses, depending on how much you're administering. There is a pediatric dose, even though we try not to use it in those patients. Things we have to worry about from a medication standpoint. interaction with similar medications, so opioids, alcohol, anticholinergic agents. You see a lot of the same side effects with this that you do of any of the other opioids: nausea, vomiting, hypotension. There is a risk of respiratory depression, especially with really large doses. Something people don't think about from opioids a lot of the time is the increased incidence of urinary and GI symptoms. So you'll have patients that have constipation and urinary retention just directly related to taking PO opioids. Tramadol is a synthetic opioid. The nice thing about that is that we're able to kind of use it to target different receptors. So when we think about how we're addressing things, tramadol is one of the few medications that does a good job of getting our mu receptors as well as the kappa and delta receptors. A caution is that it opposes serotonin reuptake and norepinephrine uptake while it stimulates the alpha 2 receptors. So if you're trying to treat somebody's blood pressure, you may have issues. Likewise, if you're administering dexmedetomidine, you may say that it's potentiated. Metabolized CYP450 as well. Something of note is that the metabolite is a lot more potent than the original. But with that in mind, it's not nearly as potent as morphine. So depending on what source you look at, it's 1/5 to 1/10 the potency of morphine. Oral onset's generally an hour or two. Most of the patients will get 6 to 7 hours of relief of it. It's not highly protein bound. The problem we run into with tramadol is that there's a long list of contraindications for it that can be potentially pretty devastating. So we avoid it in patients with seizure disorders. It is kind of nice because we don't have a lot of the respiratory effects we see with other things. The other thing that's kind of unique to tramadol versus some of the opioids is that there's not really any incidence of dependence, tolerance, or addiction. The book says there's no incidence. I think if you look at patient populations, you'll see that it's just a very low incidence. Other things, we avoid a lot of the constipation associated with things like morphine, but unfortunately, there is a high incidence of nausea and vomiting. So little trade-offs depending on what medication you're getting and kind of how it's administered. So that's why it's really important to recognize that there are a wide variety of options out there for our patients. So from there, we're just going to kind of touch on morphine, which is really the standard everything else is compared to. It's been around a long time. It comes in a very wide variety of formulations. You can use it as oral, you can use it as IV. One thing for you to be cautious with if you're looking at a patient that's taking oral morphine, just remember that the oral requirement is usually about 3 times the IV one. So make sure you decrease the dose. Morphine primarily works at the mu1 and mu2 receptor. You don't see quite as much as the kappa and delta effect from straight morphine. The similar metabolism, you do see that a lot of times the metabolite can cause adverse effects like neurotoxicity and hyperalgesia. So it's one of the reasons that a lot of times, even if we're not using remifentanil, we may administer ketamine to some of these patients because we're able to get different receptor activity. We could talk for days about the different dosing of morphine. It really depends on how you're administering it and the patient and kind of what you're trying to treat. Patients with malignant pain may be getting 30 to 60 milligrams of extended relief morphine 4 to 6 times a day. On the other hand, you may give somebody a milligram or 2 of IV morphine, and it's quite significant for them. So just be mindful there's a wide variety of routes out there as far as treatment, and then a wide variety of strengths as well. Unfortunately, basic morphine gets almost all the side effects that everything else is kind of pulled into. So you can see sedation, respiratory depression, bowel and bladder problems, constipation, urinary retention, nausea, and vomiting. One of the big issues as far as acute use of morphine for pain management is that it causes histamine release. And oftentimes you'll see that histamine release is associated with hypotension. So that may be therapeutic. Perhaps you have somebody that's hypertensive and in pain, and you're trying to treat both of those. By virtue of administering the morphine and getting the histamine release, you may see that your blood pressure issues kind of resolve. On the other hand, if you have somebody that's borderline shocky, you probably don't want to give them any morphine because they may become hypotensive. There are some theories that suggest that administering diphenhydramine beforehand can help attenuate this response. but it's still a little bit controversial. There is a risk of tolerance and dependence, most oftenly associated with the euphoria that these patients receive. Next, we're going to talk about oxycodone, which is kind of interesting. Oxycodone was originally marketed as the safe opioid, and the reason for that was that it came out in an intermediate release, an intermediate release, and then a controlled release formulation. There was no short-term or like rapid-acting OxyContin. The problem is people quickly figured out that you could do things to bypass the pharmacologic controls. So, say for instance, grinding it up or smoking it bypassed that prolonged release formulation. So it wasn't quite as safe as it was advertised. They also had a very effective marketing campaign because it was advertised as being safe. There was no risk of addiction. There was no risk of opioid overdose. People really jumped on the oxycodone bandwagon. Unfortunately, over time, we figured out that's not true at all. And I think most of the time, what we're seeing now is that it's being used for kind of neuropathic pain or like chronic pain syndromes. Again, metabolized in the liver, CYP 450. One of the nice things is that you do pick up some kappa receptors with oxycodone. Even in the oral formulation with the intermediate release or the continued release, you have a fairly onset, less than an hour, as opposed to like we were talking about earlier with something like tramadol or morphine, a little bit faster onset. And then you get a nice duration of effect. And the reason this duration of effect is really important and why we're seeing it used more and more is because we're able to get patients to a steady state and then we keep them there, as opposed to a lot of our other medications where we get them comfortable and then it wears off, or we get them comfortable and it's too much and then we're experiencing hypotension, respiratory symptoms. These patients generally will get to steady state and stay there for 6 to 12 hours. Same real worries as far as from an opioid standpoint. As I mentioned, there is less risk, but you do still have a risk of tolerance and dependence in these patients. Methadone has been around for quite a while and kind of got a bad rap for patients, primarily because of the patients that were receiving it. So methadone is a mixed agonist-antagonist, and as a result of that, we see that it's used for weaning patients off of more potent opioids like fentanyl, oxycodone, heroin, things like that. But we can also use it for treating patients with either acute or long-term pain. And the reason for that is that it tends to have a very long duration of action, as well as hitting multiple receptors. So you see that you've got a little bit of NMDA antagonism in addition to the affinity for the mu receptor. Other thing is it's generally safe for older patients because you don't see that there's a huge differentiation as far as like clearance of the methadone through either renal or hepatic issues. But you do have to be cautious with things like synergistic effects and things like carbamazepine. And then you may see that other medications have a kind of an antagonist effect to it, stuff like antiretrovirals and grapefruit juice. Because of its long duration of action and its prolonged onset time, it really takes 5 to 10 days to get to an appropriate dose for patients. From our standpoint, a lot of times what we'll do is just administer a one-time dose of PO or IV methadone. Usually we go straight to 10 milligrams, and we try and administer this before, extremely painful procedures, or if you have patients with severe pain that's maybe not well controlled by shorter acting medications. But usually what you'll see is that 110 milligram dose will provide them with 12 to 24 hours of pain. But just be cautious. The last thing you want your patient waking up in the middle of the night in pain because they thought they were going to be good for 24 hours. There's a lot of complications and medications that we really worry about having bad interactions with methadone. So you can think about some that increase the concentration, some basic things like ciprofloxacin, diazepam, alcohol, and acute use. Some will result in a decreased effect. A lot of our antivirals will do that. We try and avoid the use of MAOIs with a lot of these medications or vice versa, administering these medications to patients on MAOIs. Similar to the opioids, they'll have hypotension, respiratory depression, and there is some risk of cardiac dysrhythmias. The biggest ones we tend to see are a little bit of bradycardia and prolonged QT syndrome. Fentanyl is the most common IV analgesic that we use, and it's even though morphine is kind of the standard for most people, um, fentanyl is probably the standard for anesthesia practice as well as things like emergency medicine. Fentanyl is a synthetic opioid. Uh, if you look at it, it's actually pretty chemically similar to meperidine. But we use it for pretty much everything. And part of the reason we do is we're looking for quick gratification. So we wanted a medication that was very potent, would provide us with pretty consistent feedback, rapid onset, and then a short duration of action. Because a lot of our patients are really just being covered for the surgical pain. So I don't necessarily need somebody that's having gallbladder surgery to have 7 to 10 days of pain relief. I really just need them to be comfortable during the surgery. Metabolism is essentially the same. Um, so how we dose fentanyl really depends on the route of administration. If you think back, we talked about fentanyl is available as a patch. It's also available in an intravenous form. There is PO fentanyl as well. Sometimes we'll see patients with metastasis who are taking PO fentanyl. We may also administer it as part of a spinal or an epidural injection or infusion. And there's some places where they include them in peripheral nerve blocks. So your dose really depends on how you're administering. So say, for instance, somebody's having that lap chole, I may give them 50 to 100 micrograms of fentanyl. On the other hand, if I'm putting it in a spinal injection, I may only use 10 mics. So quite a bit of variability as far as how you dose it. Similar drug interactions, nothing really new there. Hydromorphone is kind of our heavy-duty pain medication we go to for most patients. Some patients have pretty quickly figured out they like hydromorphone and will ask for it by name. There's all sorts of good memes out there to help you with that. But we see lots of patients that need to have Dilaudid. It's available in an IV or an oral form. It's 3 to 5 times as potent as morphine when administered orally, and 8.5 times more potent when administered IV. Duration of action is a little bit longer than morphine, certainly longer than fentanyl. And usually you see it last about 3 to 4 hours. So how do we administer this? It really depends on how you're doing it and where you're doing it. Generally in my practice, I'll administer a half milligram to a milligram at a time and then repeat it every 10 or 15 minutes. Remember that your onset time is going to be a little bit longer than something like fentanyl. So don't rush and get too much in there because you may then have kind of a compounded effect on the back end. Same interactions as all the other opioids. Hydrocodone is a semi-synthetic version derived from codeine. So it's similar to codeine, but it's a lot more potent. It's also pretty much always combined with Tylenol in a variety of formulations. So Norco, Vicodin, and Lortab are all hydrocodone with Tylenol. Been around for quite a long time. And unfortunately, after hydrocodone kind of caught a lot of attention, after oxycodone caught a lot of attention, then hydrocodone also caught a lot of attention. So we were seeing there was pretty significant amount of abuse that was being done. If you go back and look 10 or 15 years ago, the pill mills in Florida and Appalachia were passing out tons of oxycodone and hydrocodone. It's metabolized in the liver into a couple metabolites. Norhydrocodone we don't really worry about, but hydromorphone is Dilaudid. So you can see how we eventually get back to Dilaudid anyways. Dosing equivalents, 30 milligrams of hydrocodone is equivalent to 10 milligrams of morphine. One of the things that's a little bit different when you look at hydrocodone versus oxycodone is it tends to have a little bit faster half-life. So while we were using oxycodone for long-term pain medications, we may use hydrocodone for shorter administrations. Other things to be cautious of, just remember that because it is combination medication, that you generally have a fairly decent amount of Tylenol in there. Depending on the preparation, it's between 300 and 700 milligrams. A little bit different interactions than some of the other opiates we saw. Some are the same things like increased sedation with other opioids, benzos, but you may see that there's other things that come into play as well. For instance, if you're giving these people mag or calcium, You may really see that there's an exaggerated response. So I commonly use magnesium as part of my multimodal pain cocktail. So I may see that those patients tend to have a little bit more sedation, a little bit more hypotension, stuff like that. Buprenorphine is a medication that's been around for a long time, but it's really come into vogue recently as far as treatment of opioid use disorder. So for a long time, we used just straight methadone. Now I think more people are probably going to buprenorphine. It tends to be stable, and then from an administration standpoint, it's generally a little bit less. So a lot of times, what you see is these people only have to get their Subutex once or twice a month, as opposed to buprenorphine they're taking every day. It's available in a wide variety of formulations as well. So there's obviously an IV formulation out there, but you may also see a PO formulation, and then there's patches and sublingual tablets as well. Nice things about it, because it's kind of a mixed picture. You get full antagonism of the mu delta and ORL1 receptors, but it's also a partial agonist at the kappa receptor. So targeting a lot of different receptors there, and by virtue of doing that, you tend not to see a lot of the severity of symptoms that you would with kind of a one-trick pony.
Huh?
Um, as far as administration, like I said, you can give it quite a variety of different routes. Just be cautious because the half-life of buprenorphine is very long. You're talking about like 1 to 3 days. So just be very cautious of that. We can use routes that avoid first pass administration. Like I said, there's a sublingual formulation as well as a transdermal formulation. Just be cautious that patients aren't receiving it through multiple different routes at the same time or multiple different administrations. So lots of times with patches, especially in older patients or those that may be confused, palliative patients, they may have 2 or 3 patches on at a time. So just be really cautious with that. Side effects are pretty similar to all the other medications. One of the things that's a little bit different is you generally don't get high from buprenorphine. So for those that are abusing it, they tend to be a little bit disappointed, and they'll look for something else. But if you have somebody that's truly trying to get off of opioids, they'll be pretty consistent with taking their Subutex. From an anesthesia standpoint, it can make pain very difficult for us to control. Same thing with methadone, but to a lesser extent, because you basically have to overcome all those receptors that have been blocked. I would certainly have them continue their Subutex. Don't stop on the day of surgery. They need that medication. So we talked about this briefly, but what if we have somebody that can't swallow pills? So there's a wide variety of routes out there. For us, I think IV is probably the most common, but don't forget about other things. Topical routes are totally fine. You may have patients that are unable to tolerate PO, but they can tolerate PR. So just kind of remember that nobody wants to go there, but it may be an option for you. Other things that are a little more common, especially for opioids, transdermal and then transmucosal. So a lot of these pills are available for like a slow dissolving capsule that they can put in their mouth. Just pay attention and see what's available for them. So there are some benefits to long-term opioid use. One of the biggest ones is that they tend to hit a stable, kind of steady state of pain reduction, and they don't have like ups and downs. There's no peaks and valleys. They tend to be very stable there, so you don't have these severe spikes. As a result of that, they tend to be pretty functional. They don't have a lot of the episodes where they can't control their pain, they can't get out of the house, things like that. Of course, there are also risks associated with that. Most of them tend to be psychological dependence, addiction, withdrawal, delirium. There is also a risk of overdose and worsening of pain. I think now a lot of patients that are being prescribed long-term opioids and being sent home that way are also going home with things like naloxone, emergency numbers, follow-up, that sort of thing. So how do we avoid a lot of these side effects that we didn't want? I called it choosing the twofer, but think about medications that do more than one thing. So perhaps medications that have a non-opioid component as well, or medications that hit multiple receptors as opposed to just hitting mu receptors. Other things you can do, rotate opioids around. So maybe your patient was responding really well to fentanyl for the first couple hours, but now they don't seem to be. consider moving on to something else like hydromorphone, morphine, that sort of thing. Other things to think about that we're not very good about as a profession, non-pharmacologic interventions. The whole reason we went into anesthesia was to give medications and make things better, but that may not be the best option for the patient. Part of that is just talking to them about what they can do that will help. Like I said, just little things like getting up out of bed may be the best approach for the patient. But you'll have people that have surgery and then they go sit somewhere for a day or two and they're in pain, when in reality they just need to be up walking. So from a non-opioid standpoint, there's a wide variety of medications, and we're going to kind of touch on those. But in general, they all have analgesic and anti-inflammatory properties, and most of them are antipyretic as well. So when we start thinking about reasons we give pain medications, commonly we see that patients with infections have pain. Say, for instance, somebody with a UTI or somebody with renal calculi. So it may be beneficial to give them a non-opioid and an opioid. That way you can charge or kind of target their pain, but also target the inflammatory processes, target and treat their fever, that sort of thing. Most of the non-opioids work in the periphery, and they help block the formation of those pain-causing substances. So, for instance, NSAIDs block the production and inhibit cyclooxygenase. When you think about Tylenol, biggest things that come to mind is pain and fever. So usually pain for adults, fever for children. It's a decent anti-inflammatory medication, but it's not the best. There's definitely stuff better out there, like our COX inhibitors. But you may see that it's a good place to start because it does so many things. You know, it provides pain relief as well as helping with fever. Just be cautious with anybody with liver or kidney impairment with really any medication, but especially with the NSAIDs. With the COX inhibitors themselves, generally we'll see that they've got a pretty profound effect on inflammation, but there's some things that go along with that. You may see that there's abdominal pain is a big one, constipation, cramps, delayed gastric emptying, slow gastric progress. So one of the things we do is try not to take it on an empty stomach because of the risk of ulcers as well as the slow GI progression. So just be cautious with COX inhibitors. These are kind of some recommended starting doses. Mind you, these are all PO doses. But Tylenol, usually we do 500 to 1,000 milligrams every 4 to 6 hours. Max dose varies. It's usually 2 to 4 grams. For the NSAIDs, remember there's more to NSAIDs than just ibuprofen. That's the most common we see over the counter. But a lot of times our patients are going to get multiple medications at the hospital before they leave. So over the counter, a lot of times you'll see the ibuprofen. This is a pretty GI safe dose here, the 200 milligrams 3 times daily. Like I said, you tend to see that ceiling effect when you get to the 400 milligram dose. Another one that's available over the counter is naproxen 220. You see that pretty commonly. And then prescription celecoxib and diclofenac, pretty beneficial. And you can rotate these NSAIDs around just like you rotate the opioids around to kind of get a variety of effects. So don't feel like you have to stick with one medication. These are some classes of kind of side medications that we use. Antidepressants are pretty common, especially tricyclic antidepressants. And what they do is increase the transmission inside the spinal cord, which helps reduce the kind of flood of pain signals. A lot of times we'll use those for patients with neuropathy, whether it's diabetic or kind of a chronic situation. Things you have to think about for these medications, they don't work quite right away. This is not a fast onset medication. Oftentimes, you're going to need 5 to 10 days to get really good coverage. So you're not going to feel better. Other times, the issue you run into is patients don't appreciate the side effects with it. Sometimes they feel drowsy. Sometimes they feel strung out. Sometimes they're just not hungry anymore. Sometimes they're excited they're not hungry anymore. You may also see that they tend to have a dry mouth. Anticonvulsants are one of the newer medications that we've really started using for acute surgical pain. Primarily, I think what we're seeing now is gabapentin, and it varies depending on your dosing, usually 1 to 300 milligrams, 2 to 3 times a day. A lot of diabetic patients or patients with chronic pain are either on this or have been on it, but we're seeing more and more often we're giving like a once or twice dose of gabapentin early on before surgery, or one before surgery and then one during the hospitalization. Other medications to not forget about, things like Tegretol, Topamax. Again, all these are primarily targeted at neuropathic pain, but we may treat that neuropathic pain before it becomes a problem. There's also a variety of skeletal muscle relaxants out there. We're really bad about remembering the muscular component of things. We generally think about people having surgery and it being bony and there's a fracture, but we forget that all those muscles have been displaced and stretched and torn as well. So I think a lot of people now are giving Robaxin primarily because it's available as a PO and an IV formulation. Before that, I think the go-to drug was Soma. The problem we ran into with Soma was there was a high incidence of overdoses. And then also forget basic things. Topical medications work very well. They're almost all available over the counter. There are some compounded topical medications out there. There's some that'll have like ketamine and ibuprofen together, or ketamine Precedex ibuprofen. Whatever you think about, you can probably find it somewhere. And like I said, as far as all these topicals, you can get them over the counter. Other things we forget about, non-pharmacologic medications and non-pharmacologic options. For somebody with pain, you really need to think about a comprehensive picture. So part of that may be something as simple as massage or movement. If this is somebody that's bedridden, are they going to physical therapy, or is physical therapy coming to them? Other things that are considered a little bit less traditional: hypnosis, acupuncture, a lot of benefit there. Yoga and Tai Chi, again, a lot of benefit. Now, with that being said, if you weren't into yoga before, I wouldn't plan on yoga suddenly making your life better just because you have surgery. There are exceptions, but generally patients don't do very well with that. Other things to consider, kind of basic stuff: temperature management, talking to people, getting them in touch with somebody to talk to more, administration of epinephrine, administration of, had a brain for there. I don't remember where I was going with it. Oh, you may see that administration of things like cold will help kind of dull the sympathetic system. So as a result of that, they don't get those sympathetic surges. They don't get that epinephrine that you see oftentimes. I think one of the big things we're seeing right now is like cold baths, or like ice plunges. Those seem to offer a lot of benefit. Some people will work up to that by doing cold showers. Maybe as little as 15 to 30 seconds a day kind of starts to help dull them to that sympathetic stimulation. Other things kind of considered complementary alternative, just talking to somebody about things may help. A lot of times we see that patients with painful stimuli that aren't managed very well early on tend to develop psychological complications. So getting them into counseling may be beneficial. Things like yoga or Tai Chi may allow them not only to mobilize and stretch, but it may also help them work through any sort of long-term complications they're experiencing. So we try and consider getting patients off of opioids early on, but there's some patients that we try to do it a little bit sooner. And part of that is because of perceptions of opioids. One of the biggest things that we see is patients that have a fear of addiction. And addiction means many things to many different people. It may be somebody that was truly addicted, so they're trying to avoid opioids altogether. You'll have lots of patients that come in for surgery with a history of opioid use in the past, and they would much rather be in pain than get opioids, which obviously isn't a good strategy because we talked about all the adverse outcomes that you can get through, pain. Or you may have patients that had a loved one that had an addiction, and as a result of that, they're worried that they're going to die because their loved one died. So they may want to avoid it for totally different reasons. You may also see that they're not able to really participate or deal with their plan of care because of functional limitations. So it would be great if somebody could get up and go to yoga or Tai Chi or go to physical therapy. But if they're bedridden, they may not be able to do exactly what you want them to do. They may be able to still do some sort of exercises in bed, but it's not going to be normal by any sort of respect. The other thing is, as far as opioids, it's not a good medication for chronic pain, but you see that there's lots of people that throw opioids at it anyways. Part of that is generally to like satisfy the patients. Part of that is to make them feel like they've done something. We're seeing that a lot of patients that previously would have been on long-term PO medications for chronic pain may now go get a stimulator placed or get a neural pump placed to administer their opioids that way, and they tend to do pretty well with it. So as far as the dosing, there's kind of a couple different approaches that we deal with. Most of what we see is really like the initial dosing. So somebody that's opioid naive, that's really just getting opioids for acute pain. After that, we tend to see a little bit of an up titration, and that may happen as soon as PACU. So say, for instance, you had a patient that was, well managed with fentanyl during the perioperative period, but then they got to PACU and that just wasn't good enough. Part of that's because a lot of times while they're in the operating room, they're receiving multiple medications. They're getting those volatile anesthetics. All those things really help out with analgesia, and then they get to recovery, and it's really back to like one or two agents. So we may see that even though they were well controlled with fentanyl in the operating room, by the time they get to the recovery room, they need something more. So they may need Dilaudid at that point. So we try and provide options for up titration for these patients. The other thing is, what is the maximum dose? Um, as nurses, we tended to get very focused on the maximum dose of things. And there are truly some ceiling effects where you're not going to get any more benefit out of that medication. But very rarely do we have a true maximum dose of medications. The maximum dose, with that in mind, or at least the concept of a maximum dose, is very different for somebody having that lap chole done versus somebody that's on palliative care with metastatic pain. So part of it just depends on your comfort, part of it depends on the patient's condition. Lots of things you really have to take into account while you're dealing with these conditions. Other things that we can consider for patients is something that allows them to have control. So you may have used a PCA or a patient-controlled analgesia pump in the hospital. Patients can also go home with these, and it doesn't necessarily mean a opioid PCA pump. We also see these connected to spinal cord injections. We see them connected to peripheral nerve blocks. So the nice thing about that is that it's really a little bit safer. Um, Now, there is potential for abuse, but usually these have a lockout feature that prevent patients from getting too much medication. Now, there are ways around it. Somebody's asleep and somebody just keeps pushing the button for them. But for the most part, it's a pretty safe and reliable means of controlling patients' pain. The other thing is it really lets them feel like they have some control over what's going on in their life, especially at a time that there may be very few things that they have that feeling. The other thing is generally these are portable with a long duration of action. And when I say duration of action in this respect, I don't necessarily mean the medications, but you're sending them home with a very large amount of the medication. So that way they can usually get 5 to 7 days out of it, as opposed to something that's got to be changed out every couple hours. So if you had somebody that's maybe going home on palliative care, it may be a good option for them because they're able to have a little bit of control, they have some autonomy, but it also lasts them quite a while. So these are just some examples of different dosing for different medications. I know you guys have gotten like 9 million different dose charts. The big thing I really wanted you to take away from here is comparing the oral to the IM to the IV dosage, because there is so much variation there. But it gives you kind of a good reference point when you're converting things from, one route to another. These are really specific examples for these medications without having the range. This chart was kind of busy to me. This one was really a little bit more simple. Uh, Other things to think about: if you have somebody that comes in on PO medication, how much IV medication do you need to give them to get to the same respect? So, for instance, if I have somebody that's taking 30 milligrams of PO morphine twice a day, um, giving them a milligram or two of morphine may work for somebody that's opioid naive, but it's probably not going to help them at all. So you may have to start off with a 10 milligram dose, which sounds crazy, but because their tolerance, that's basically where they've gotten to. So now we're going to talk through kind of some common cases that you may have to deal with. They may be surgically related, they may be non-surgically related, and you're really just being consulted for acute pain management. So Mary's a 70-year-old female. She's got spinal stenosis, leg pain, and weakness. So part of this is intentionally vague. With that in mind, what do you think about Mary? What could be going on here, other than her obvious spinal stimulation?
Lack of mobility.
So lack of mobility. What else? Is the leg pain new? How bad is it?
Probably chronic.
Is it chronic? Think about some of those red flag symptoms we talked about. Is this potentially somebody with spinal stenosis that now has a vascular insult? Or do they have new nerve compression? Think about, loss of bowel or bladder function, things like that. So thinking about Mary's pain, how would you describe this pain? So we talked about it's probably chronic pain. It's probably not acute. But do we think this is maybe a little bit of neuropathic pain? A lot of times with patients that have spinal cord symptoms, we'll see that they have a little bit of neuropathic pain on top of other types of pain as well. It may be nociceptive, it may be neuropathic at the same time. So what else do we want to know about Mary?
Is it affecting activities of daily living and stuff?
Sure. Can she get up and walk around? Is she bedridden? So to kind of add some more details for you, you get called down to the emergency room because they're not really sure how to manage Mary's pain. She's a little bit older. They're concerned about pulmonary complications. So what sort of medications could we give Mary that maybe wouldn't have as many pulmonary complications to help her with her pain?
Gabapentin.
So gabapentin would be a great option for her. One of the things you do have to worry about with gabapentin, especially in older patients, is there's a little bit of a risk of increased sedation. Generally, we see it with the higher doses, but gabapentin would be a good choice. What about basic stuff? What else could we give her?
Tylenol?
Yeah, exactly. Think about things like acetaminophen, ibuprofen. Toradol may be a good start for her. What about assessing her? Hopefully the ER has already done it, but what do we want to know about her spinal cord stenosis? She's probably going to need a CT or an MRI to make sure that she doesn't have any sort of progression, especially if we have any of those red flag pains. So she's 70, she's got some issues. We don't know anything as far as what medication she's already on. We've kind of covered some good non-opioid alternatives. What else could we consider for her?
I guess more of those long-term treatments that you mentioned, like methadone or something like that.
Yeah, exactly. So a lot of times with these patients, especially if they're a little bit older, we try and go to something that's a little bit more of a mixed picture. So instead of giving more of a traditional opioid, we may look at something like buprenorphine or methadone because we don't have a lot of those complications. And that way we can kind of get her to this steady state without the risk of sedation, without so much, pulmonary complications, hypotension, respiratory depression, those sorts of things. So that's definitely a good thought for her. All right. So David's an 86-year-old nursing home guy that comes into us with a new stage 5 DQ. He's bedbound, he's contracted, he has no sort of daily function at all on his own. It seems like he's eating less, his weight loss is really accelerating. He doesn't really interact much. He's moaning with care. Surgery wants to take him to the OR to debride this new stage 5 DQ. So what's your anesthetic plan for this guy? Not even just pain. How are you going to anesthetize him?
Probably Tiva.
Okay, so Tiva is not a bad option. Why are you thinking Tiva?
Just because of his age and he's already demented.
Okay, so that's a thought, not affecting him so much from a cognitive standpoint. What else?
Regional anesthesia?
Okay, so we could do regional anesthetic. What type of regional would we do for somebody with a stage 5 sacral DQ? We got quiet all of a sudden. It sounded really good.
Could you get a QL on this guy, maybe?
So QL generally works a little bit more in the abdomen as opposed to on the sacrum. You could do a sacral ESP. Something else you may be able to do is just a spinal. That may be an option for you. things that may make it difficult depending on how he's contracted. That could be hard. Other things, oftentimes when you have patients that have like stage 5 D cubes, there's not a whole lot of sensation there. So you may be able to just do it with the surgeon infiltrating some local and maybe a little bit of sedation. The one factor that comes into play with this guy that's going to make it really hard for you is that he's got dementia. So the anesthesia plan may be more at targeting controlling his behavior from a dementia standpoint than really, sedation and analgesia standpoint, because he may not have a lot of sensation from that ulcer, but positioning him weird, we're not going to be able to do this with him supine, obviously. So he's either going to have to be lateral or prone. That may be very difficult if he's contracted. So that may force you into kind of doing a general anesthetic because you're not able to control him from a behavioral standpoint, not so much a pain standpoint. So all good thoughts. So the other thing to think about is, does David have pain? Obviously, he's been laying on this for quite a while, so he may not have a whole lot of sensation there, like I said. The other thing to think about at this point is, where does David go from here? So we take him to the operating room, we debride it. Probably want to think about a little bit longer term solutions for this guy. He may need to start looking at like palliative care or hospice, something like that. Kind of clues in there. He's eating less. He's losing weight. He's not very interactive. It doesn't sound like his mental status is the greatest. So David may not be with us for very long. So that's something to think about.
Hey, Dr.
All right.
Steve,
Yes, sir.
would you give that gentleman albumin preemptively?
I would definitely consider it. It depends on the facility you're at. And it also depends on the service and the surgeon. It sounds like from a nutritional standpoint, he's probably not doing real well. Albumin would definitely be a great start, but this may be somebody you consider more like putting on TPN or some sort of enterogastric feeding to kind of supplement his nutrition. I don't know how much he's eating, but a lot of times what we'll see is in lieu of like true PO intake, that we'll put these people on like protein supplements, like protein shakes and stuff like that to try and boost their nutrition. The problem is, just like you guys saw when you're in the ICU, you put in a Dopoff, you start feeding him, he pulls the Dopoff out or he pulls it halfway out and aspirates. So it kind of comes to a point there where you, between whoever's managing the patient and the family, they really need to have a serious discussion about where this is headed and kind of what the family's wishes are, what they think his wishes would be, that sort of thing. But anticipating if I'm going to do a general anesthetic, I would probably try and get some sort of volume in him, and albumin would definitely be a good choice as far as us assuming he's malnourished. The other thing you'll see when you start talking about albumin administration in these patients, so many of our medications really need protein for transport. If it's not there, it tends to have very long onsets, and then we tend to have a lot of free medication sitting around. So early administration of albumin may be beneficial from that standpoint. All right, so this is a guy that we're going to do a thoracotomy on because he's got lung cancer, but he also has pelvic pain. He's got metastasis. He's got pretty severe pain, 8 out of 10 in his pelvis. Keeps him awake. It limits his mobility. We don't see any sort of deficits, but when they look at his pelvis, he's got a big lytic metastasis. So lots of things we've got to think about here before we even get into his pain management. So if we're going to do a thoracotomy on this guy, how are we going to position him? Laterally. So how well do you think that lytic metastasis is going to do if he's laying on it in a weird position for hours? Probably not real great, right? So positioning is definitely a concern for him. The increased pain that will come from that positioning is another concern. So just be very cautious. Lots of times we get focused on one thing and don't think about the big picture. He may hurt less from his thoracotomy than the fact that he's been laying on that lytic metastasis for hours. The other thing you may see is that sometimes we wind up with like pathologic fractures in people that already have lytic lesions. So just be cautious about how we position them, how we move them around. So we get a little bit further into his history. He's been on intermediate release morphine pretty good. So he's taking 30 milligrams every 4 hours. If we were going to give him an equivalent IV dose, how much would we give him?
10 milligrams.
About 6 milligrams, right?
I think Pal said it or somebody. Yeah, 10 milligrams. So remember, your 30 milligrams goes down to 10 milligrams if we're giving it IV. Unfortunately, that 30 milligrams has stopped working now. He's probably taking it more than what he's telling us, and he's only getting a couple hours of being pain-free. So with that in mind, what do you think we could do from a pain management standpoint? We're already giving him, say we gave him that 10 milligrams of morphine and he's still in 6 out of 10 pain, and we haven't even started the anesthetic part of this process. What else could we consider for him?
Can he take PO meds?
He can't take PO meds, yeah. So we can give him whatever we want.
Oh, give him something longer acting then.
All right, so what do you think might be good as far as a longer acting medication?
Oxy maybe?
Yeah, I think I would definitely consider oxycodone for this guy. I would probably not do the intermediate release. I would probably do like the continuous relief where I can get more like 12 hours out of it. But I think oxy would definitely be a good choice. We can also kind of review what he's taking from a non-opioid standpoint. And then as far as an anesthetic plan, what are we going to do for this guy to try and control his pain in the operating room?
Guess you could start him on a drip.
Okay, what kind of drip would you start him on?
Ketamine?
So ketamine may be a very good option for him. That may be something he can take outside of here. Whether he is able to do like small IV doses of ketamine on the floor and pack you, that may be an option for him. He may be able to go to a ketamine infusion center. That may be an option for him as well. The other thing is just talking about ketamine in general, there's actually a nasal spray ketamine that's available. I think the VA uses it a lot of times for depression. It works not quite as well as some other things like the IV formulation, but you may be able to use that for pain at home. That's definitely a consideration. Non-opioids may be an option for him. And then what else do we want to think about as far as medications for this guy? When he goes to the floor, what do we want to consider?
You could think like some Presidex too. You could go to the floor with Presidex.
Yeah, Presidex would be another good option.
Fentanyl patch, PCA.
Yeah, fentanyl patches and PCAs may both be a good option. I personally try and avoid patches if I can in patients that are in the hospital. I try and get them a little more stabilized before I transition to something like that. So if this guy's already on like extended release oxycodone, he's probably past the point of a lot of the benefit for fentanyl patches. Maybe not necessarily entirely. It really just depends on if he responds to the oxycodone. I just want to be cautious of putting him on like a long acting thing like oxy and then fentanyl patches at the same time. So, generally I do one thing, see if it works, and then move on to something else. As far as while he's in the hospital, especially like immediately post-surgical, that PCA may be a great option for him too. And then something else to think about for this guy, potentially an epidural, because we've got pain in multiple sites, right? Because we're getting ready to do a thoracotomy. He's got lung CA, and then he's also got pain down in his pelvis. So an epidural may work well for him. You could also consider like a regional nerve block. Again, it may be a little bit harder just because you have pain in two different places, but that's a good thought as well. And then these are just kind of some guidelines when you start thinking about PCA dosing for patients. So generally the way we set it up is that we'll have one of two kind of schools of thought. So you may have it straight demand, where when they hurt, they push the button. But the problem with that is we have a hard time getting them to a steady state. So if I'm using a PCA for breakthrough pain, that's okay. So say like I give this guy the oxycodone and that's kind of his maintenance pain medication, and I just want the PCA available for when his pain gets worse than that, or he's doing something he knows is going to be uncomfortable, then I can go with just a demand dose on that. And these are some examples of demand doses for different medications. But if I have this as really my primary analgesic, I want to have a continuous infusion of that medication so it keeps him comfortable at baseline. The one thing you have to think about is how much do I want my continuous infusion to be? And part of that is you really have to go back and look and see how much opioid or opioid equivalents or morphine equivalents he's gotten in the last 24 hours. That'll be a good reference point for you. So say in the last 24 hours, he's gotten, 24 milligrams of morphine. So 24 milligrams or 1 milligram an hour may be a good continuous infusion. And then I want to be on the safe side. Some places, patients that are on PCAs have to be on oxygen. Some places they have to be on continuous pulse oximetry. Some places they even have to be on capnography. So that's a caution. The other thing is to think about how long you lock them out between demand doses. The last thing we want them to do is not have any sort of barrier there, so they're able to constantly administer multiple demand doses to the point of almost being an overdose. 10 to 20 minutes is kind of a common reference for lockout intervals. So you'll see 10, you'll see 15, you'll see 20. Some will be shorter than that, but most of these medications have a duration of action that's a lot longer than that. And that'll get you enough time for onset, but it also gives you enough time that they should be comfortable. So lockout 10 to 20 minutes is pretty common. We can also put opioids in our neuraxial agents, and in fact, that's pretty common, I think, everywhere now. The medication may vary, but I think it's pretty common that everybody's putting some sort of neuraxial opioid in now, whether it be spinal or epidural. And sometimes what we'll see is that patients that have an epidural in place will actually kind of give them like an epidural top off of an opioid before we pull it. Duramorph is a pretty common agent that we use for that because it does provide a little bit longer duration of action than something like fentanyl. But pretty much any of our opioids can be used intrathecally. But I think the most common ones you see are fentanyl and morphine. So these are just some examples of dosing for you. Keep in mind your spinal dose is going to be significantly lower than your epidural dose. The other thing you'll see is that a lot of times our continuous infusions of epidural medications will already have opioids added to it. I think probably one of the most common ones we see is either bupivacaine or ropivacaine with fentanyl in it. It's usually like 2 mics per ml. So they're getting kind of a continuous supply of opioids in that as well. All right, any questions about stuff? I'll take a look at the questions here real quick. Kyle asked if you'd be expected to know everything within the slides or what I highlighted. Mostly what I highlighted, but there's a lot of information there. I would make sure you're familiar with the different pain control theories. I would anticipate lots of scenarios where you have patients with pain and you've got to kind of figure out how to address things. There may also be questions about, big things that are different. So if you look at your opioids, there's a lot of similarities there. So I would look for the outliers. This medication may increase your risk of seizures or should be avoided in somebody that has seizures. This medication is a synthetic. Something basic like we just talked about, how to convert somebody from PO morphine to IV morphine, that sort of thing. A lot of your non-opioid alternatives. So there may be some questions about, which of the following is a skeletal muscle relaxant? What would be an appropriate dose for acetaminophen? Questions like that. And then kind of how those medications work. Omar asked if you could do a sciatic block with an approach around the wound. You wouldn't do a sciatic nerve block, but you could do an erector spinae at the sciatic level, and that would get it. Yeah, Mark's exactly right. It sounds like he's not going to be around very long. Other things to think about, Marlea said it, hit more receptors. A lot of times, if you can use agents that hit multiple receptors, you can use a lot lower doses, and that helps you really avoid those kind of side effects. So instead of just doing one agent, do multiple agents. It may be a little bit more work for you, but your patients usually benefit from it. So, figure out how to hit those receptors and what you can do. So when you look at the opioid-free analgesic PowerPoint, a lot of it's what we already talked about today. There may be some specific questions on there, but most of what's going to be on there is stuff we just talked about, kind of alternative approaches to things. For instance, you'll see that a lot of the PO medications are on there. So, an appropriate dose of Tylenol or Tylenol may be okay for this, or, I should give this patient Robaxin because they've got, muscular pain, that sort of thing. So not so much that explicitly, it's really just a reference for you. But you'll see that there's a lot of overlap between that PowerPoint and the rest of the information. There will be a little bit of exam one material on this exam, but a lot of it's going to be new stuff. There's just so much information in all these different lectures that there's not that much overlap from one to the next. But things that you thought you might need to know, I would probably make sure I was still familiar with them. And like I said, and you guys will hear me say this again and again and again, and even when you get to clinicals, everything we're telling you, you've got to know. It's not just a studying for a test. This is stuff you're going to need in your everyday life. All right. Well, that's all I've got. You guys have a good week. I'll see you on Thursday. And I'll let you know as soon as I hear back from the Maverick folks.